So we are live now.
Good evening. This is Dr. Chandramohan from SaiRaM Physiotherapy Center, orthopedic and sports physiotherapist. A warm welcome to all participants for the ExRx India's and SaiRaM Health Services Private Limited's presenting WEBATHON series, Enthusing for the World Record. We will set world record in this series in association with Fecal Studio, Chennai, SaiRaM Academy, Chennai, DusaT Creations, West Bengal, powered by Dr. Venkatesh's Stimulus Physiotherapy and Fitness Clinic, Pune, Maharashtra, India. ExRx India's 146th topic is Childhood Obesity. Will be presented by Dr. Janani Ravi, MPT, Pediatric Physiotherapist, SaiRaM Academy, Chennai. I welcome ExRx India members, Dr. Rupesh and Professor Duna and our associates. Now I welcome Dr. Janani Ravi to present our topic.
Thank you, sir. Thank you so much. So first of all, I would like to thank Chandramohan sir and the team for once again bringing me here to present in this great platform. And I also would like to thank Arunachalam sir for helping me and guiding me in all my steps. Sir, can I share my screen now, sir?
Yes.
Yes.
Please share your screen.
Ma'am, can you...
Full screen, please.
Yeah, okay. Just a minute, ma'am.
Yes.
Yeah, is it okay, ma'am?
Yeah, it is visible and you can continue, please.
Okay, thank you, ma'am. So good evening. In this session, we will be seeing about or looking into the childhood obesity, which is an epitome of the current trend in pediatric health. So do you think there is some difference or more difference between the childhood obesity and the adult obesity? Or is there no big difference, or what is it actually what is this obesity actually going to do in childhood? So these are the different questions that would definitely arise among all of you, and these are a few questions that we will be addressing in our session. So to have an outline of our session, so we will be looking into the magnitude of the childhood obesity across nations, and then we'll be looking into what are the common risk factors that can contribute for the childhood obesity, and what are the common preventions that we are supposed to take in order to prevent this childhood obesity, and a few barriers and how to overcome those barriers in managing childhood obesity. So these are the contents of our session. To start with, this is a quote which was published around 2 decades ago, which states that the rise of childhood obesity has placed the health of an entire generation at risk, which specifically talks about that if, for example, if a mother or a father is found to have or have become obese during the childhood phase, then obviously the next generation or the upcoming generation of that particular person or that particular family is going to land up in obesity. There are more chances. I would not tell that all the obese parents would definitely land up having obese children, but there are maximum possibilities, and this could become 100% if we do not take the required steps at the moment. So that with that quote, I would like to start the magnitude of the condition. So if you see, this is the prevalence rate which has drastically increased over a period of time from 1995. So in the upcoming slides, I'll be showing you what was the trend of this or what was the prevalence of this childhood obesity in the year 1975. So how has it drastically or dramatically improved or increased over a period of time? So if you see here, which is about 24% of overweight and 43% of obese children, which is not just simple, which is actually a major part or which prevails majorly in the society. So which tells that we are supposed to be of concern in childhood obesity. So this is another reason which tells that if a child is found to have obese, then there are 5 times more chances that this particular child can become an adult with obesity. So it is not only going to stop with obesity, even during the childhood phase, the child is going to face many problems, many comorbidities. Again, during the adulthood phase, along with the obesity, the adult is going to face n number of problems or morbidities, which can be cancer or to be of less importance, it can be diabetes, it can be hypertension, cardiovascular problems. So these are a few issues that not only happens in case of adults, but also in case of children. So again, once again, if we do not prevent this condition at the childhood level, it is going to give us more complications in the adult period also. So, and one more difference that I would like to tell is when it comes to obesity in adult, the scenario is different because as an adult, we know how to deal with obesity. We know what are the things, what are the measures that we are supposed to take. But when it comes to a child, the majority of the work should be done by the parents and by the healthcare professionals like a physiotherapist or by the teacher or a physical educator. These are the members who will be playing a major role in case of a childhood obesity or in preventing a child to develop a serious condition. So this slide states that one among 3 children in UK are found to have either obesity or overweight, which is, as I already told you, a great number. Imagine if the population of the UK is around 3.5 million or so, then 1 among 3 is going to be a very huge number. So this is again a prevalence. So please do not get confused as I'm giving you too many numbers. This is just to state or open your eyes, stating how common this problem is present in our society and why should we take necessary actions to actually prevent this condition or to manage this condition. Because there are many parents who just ignore this condition, stating, my child, he's just looking plumpy or he's just overnutrition and he does not have any issues like overweight or obesity. These are the common things that as a physiotherapist, we tend to listen when we say that his or her child has obesity. So to overcome all these things, so as a common person, what do we think? Okay, fine, maybe as a parent, whatever they are telling is true. So we just tend to neglect the problem right there itself. So that those are not the things that we should be doing as a healthcare professional. So this is again the percentage in the year 1975. So it was just 1% of either overweight or obese children between the age of 5 to 19 years. Whereas if you see, that has drastically increased in the period 2016. These are just the data which are accumulated over the period of a time. So in the year 2016, again between the children of 5 to 19, it was found that 340 million children, this is not just a number, right? Not a simple number which can be neglected. So which between age of 5 to 19 years, and going again, coming to the forward one, 2019, which is so recent, according to the data, in the year 2019, it is stated that 38 million children of age less than 5 also were found to have either obesity or overweight. So as I already told you, this is definitely a reason to be of concern. To put it in a better words, it is definitely a global concern. So here again, once again, so this is just a nationwide prevalence which states that, which shows us what are the prevalence rate of obesity among different nations. You can see here, India is just one among the least, but it is not least. Though there are no space to actually put up all the nations. There are so many nations who has developed childhood obesity for the past few decades. So India's, it will not take much of time or much of decade for India to just reach the top 1 or 2 places, whereby which means childhood obesity is going to reach heights or highest in India also if we do not take the required steps. So now that we have seen whether is this topic important or not, I hope that I've given you just an idea stating what is the prevalence and what is the magnitude or trend of this condition in our society. So now coming to the definition. So according to Center for Disease Control and Prevention, so overweight is defined as a BMI at or above 85th percentile. And we classify children as obesity if they have a BMI percentile above 95th. So I'll just tell you what are these percentiles. So it is similar to the adult BMI. So we have adult BMI, which is just calculated based upon the height and weight. But in case of children, it is not only the height and weight that should be taken into account, but also the age. So age should also be taken into account to assess or to give a proper number of BMI. So which is already being given by the CDC center. So we have two different growth charts, which you must be knowing, which is commonly used by any pediatrician. So we have a separate chart for the females and for the males. There are few differences. So this gender difference is basically due to the body mass or the body predisposition. Because of that particular difference only, we have a separate one for boys and girls. So coming to this percentile which I was talking. So for example, when do we say, as I already told you, just 1 second. So as I already told you, so here we have the BMIs, and this states the percentiles, and here we have the age. So this, as I already told you, this can be used for children between 2 to 19 years commonly. So after 19 years, we commonly tend to rely upon the normal BMI, as there is not much difference is going to be there. So as I already told you, this horizontal line states or determines the age of the child, and this vertical line says the BMI. So for example, if a child of 10-year-old has a BMI, so why do I tell it is age matched? Yes, we'll see now. So for a child of 10-year-old, so if the child has a BMI of 18 or so, so we tend to call that as normal, okay? Or which just lies between third percentile. And for example, if the same, okay, so if a child around, I'll just give you a few examples for you to understand. So again, if a child is of 9 years old, has a BMI of somewhere between 21 or so, so if you see, it falls under 95th percentile. As we already saw, if a child is at 95th percentile or above 95th percentile, we classify the child as obese, right? So a 9-year-old who has a BMI of 21, we tend to classify the child as obese. So similarly, if the same BMI, if around 14 years or so, if a child of 14 years has the same BMI, then the child is not come under either overweight or obese. So this is how we are supposed to make use of the growth chart. There is just slight difference between the male and female growth charts. So why am I talking about growth chart here is this should be taught also to the parent, for the parent to moderate or keep a progress on the BMI or just height and weight of the. So now we have all the BMI calculators online itself. So these are the basic things that we are supposed to teach the parents, so that they'll have a look into, they'll have a view into all these aspects, which are a major part in determining either the child has overweight or obese. So coming to the risk factors, so in case of risk factors, these are the common risk factors which can lead to childhood obesity, such as genetic predisposition. If a parent, as we already know, if there are parents with obesity, then there are more than 50% of the chances that their children might also develop obesity, and decreased level of physical activity, and environment that inhibit active living. Right now, the current situation is one of the major causes, which is the COVID situation with all these lockdown. I bet more than 50% of the children after this lockdown, when they go to school, are going to completely become either overweight or obese, because as this environmental inhibition of active living plays a major role in the child's health, especially for children aged between 3 to 7, where all the fat deposition or fat tissue starts developing. So that is the age when children have to start playing more, or even better words would be should have more of physical activity. So only then the deposition of the fat tissue does not happen drastically. So the next causes could be the larger portion sizes. So these days, often parents, what do they do? Because either because of their work pressure or whatever, so they just load children with more food, not many meals. For example, we often recommend parents to give children many frequent meals but small bowls of food. But parents do not often do that. What do? In turn is they try to club 2 to 3 meals at a time, and they give as a larger portion, which also might lead to this obesity. Then again, as we already know, it is energy drinks, which has more of this carbonated drinks or sugary drinks. These are the ones that these days children are actually requesting and wanting. They just do not want any good foods. They do not want any vegetables to be taken, but they go into having all these. And what do our parents do? They just give the kids whatever they ask. That is one of the major issue in the current generation. So these are the risk factors that could develop, that could maximum lead to a childhood obesity. So with this, another important risk factor is obese mom. As we already saw, a genetic predisposition, it is not only father but also mother plays a major role. Why? Because not only during the period of conception, but also during the reproductive age, or even better, right from the time of puberty, the female should have a good eating or a good exercising. Only if the mother or the female tends to have a good exercise routine or good eating routine, then there are less chances for the child to develop this particular obesity. So with this, we will look into what are the concerns or problems that can happen if a child is found to have obesity, not only adult obesity, but also increase in the cholesterol levels, hypertension, or one of the important points that I would like to add here is not just increase in developing diabetes, that is type 1 diabetes. So often we notice children having type 1 diabetes only, but recently it is found that type 2 diabetes is also being seen commonly in children, which should not be a scenario at all. So imagine what if already children are more prone to develop this type 1 diabetes because of all the hormonal changes and because of all other fetal problems. So along with this, because of the environmental changes, the children now have an additional risk of developing type 2 diabetes mellitus also. So again, because of all these, there are chances that might increase the absenteeism in the school, which again is going to lead or make the child a poor academic performer. And with all these things, if the child is tend to have obese, that can definitely lead the child to participate poor in the activities, because of which the child will not be able to match their peer, which is going to lead to depression or low self-esteem or confidence. So these are the common harms or common long-term problems that a child with obesity might have. So with this little information, I would like to tell that what can we do to prevent this particular condition. Even before we find a child with obesity, what are the ways we could prevent? So it is just so simple, regular activity. Regular activity is more than enough for a child to prevent this particular condition. So as we already know, this regular activity is going to increase confidence, self-esteem. Along with all these things, what are we going to do? Okay, so it is 180 minutes of exercise, or I would not use the term exercise, it is just physical activity. So 180 minutes of physical activity should be encouraged for a child less than 5 years, as I already told you. So as the fat deposition or the development of fat tissue happens between 3 to 7 years, so that is the time when the child has to become or be more active. So 180 minutes of exercise or physical activity is definitely important for a child less than 5 years. So once all these gross motor functions has been developed, so after 5 years, the child or the adolescent just requires 60 minutes of exercise per day or physical activity. So this physical activity can be divided into either a moderate activity or a vigorous activity. So these are just few examples of what the common moderate activity that can be given. As I already told you, exercises are a structured physical activity. We are not going to prescribe the child with all such prescribed physical activity, so-called exercise. So we are just going to involve the child in the physical activity, in just normal routine, so that the child finds it easier to do and the child enjoys it when you keep shifting the activity or just keep changing the activity. So cycling on a flat ground, walking to a school, playing in a ground. So these are the moderate activities that can be given for a child for about 60 minutes, and vigorous activities such as swimming, running. So to be more precise, you can help the child or you can just put the child in a specific classes so that the child tries to learn and also enjoy doing that particular vigorous activity. So the difference between this moderate activity and the vigorous activity is the amount of energy that is being consumed. So that is the difference. So if it is, for example, in case of moderate activity, it is going to be just 3 to 6 metabolic equivalent. So when it comes to vigorous activity, it is going to consume more than 6 metabolic equivalent. So that is the difference between a moderate and a physical activity. So with physical activity, the children become more fatigued. Whereas when we start up with just moderate activities, once just starting with the moderate activities and then continuing vigorous activities is actually going to help the child in maintaining the vigorous activity. And again, these are few examples of bone strengthening activities and muscle strengthening activities. So again, these are specific exercises that can actually be given if the child enjoys doing it. So this is an example of exercise recommendation that can be given in order to prevent obesity. So the common rule that we apply is 5-2-1-0. So 5 means 5 or more meals of or more bowls of fruit servings or vegetable servings should definitely be given for the child. So along with that, 2 hours. So less than 2 hours of inactivity, or to be more precise, less than 2 hours should be only encouraged in front of a TV or a system or laptop or mobile or anything which just inhibits the activity. So that should be only for 2 hours or less than 2 hours, and then which means 1 hour of physical activity. 1 hour of physical activity, which is again 60 minutes, which we've already seen. So this is applicable for children after 5 years or so. If it is a child less than 5 years, so this bowl servings and the hour of activity is just going to increase. Okay, and it is another coming to 0. 0 is we cannot directly put it as 0, which means that we are supposed to give the children with low fat milk, or it can be 0% of sugar foods. So though that cannot be directly applied, we have to try to limit the sugar intake in children. So that is about this rule. And next, coming to the steps, 10,000 steps each day should be encouraged. It's really very, very difficult. It is easy for us to say. It can be easy. All the exercises that I would be telling now, or all the physical activity, all the management that I would be telling can just seem to be easy for you. But it is very hard when you practically apply this on the child. It's because they are not like adults. Even as an adult, we still do not understand the efficacy of performing an exercise and the morbidities that might develop if we do not have a regular activity. So when it is a scenario in adults, then imagine the condition of children. It becomes very hard for us or as a parent to actually teach the child or make the child perform all these activities regularly. So we have more practical difficulties. So that is why I'm giving you variety of sessions or variety of recommendations that you can apply here and there. Okay, you can combine it together and you can apply it to the child. So then it is 10,000 steps each day should be recommended. So even if the child cannot perform at 10,000 steps, minimum of 2,000 steps should be done or should be performed by a child, because only after 2,000 steps, 100 minimum calories would be burnt. So that is one of the recommendation. And the other recommendation which we have already seen is participation in either a moderate or vigorous intensity of physical activity, which can include 60 minutes per day. And this 60 minutes per day should be done for about 3 days or 3 times weekly. Why 3 times or 3 days is because if a child does an activity for 60 minutes, then the benefit is going to last only for about 24 to 72 hours. So for that reason, it is mandatory for us to encourage the child to perform exercises for at least 3 times weekly. Next, coming to at least 4 to minimum of 3 times. So if the child is happy doing that exercise, then it can be exceeded to about 4 to 10 hours per week, which can be because it can be a moderate exercise or it can be a high intensity exercise. Any exercise which is done more than 4 hours per week to maximum of 10 hours per week is definitely going to shed the weight of the infant. So that's about the exercise prescription to prevent obesity. And these are few health consequences as a physiotherapist we should be seeing. So I've just given the basics. So not that all children would have, and not that no children would have this. These are the conditions that you might notice when a child just comes with overweight for a long time. So first is definitely obesity is going to have a greater impact on the body's response to weight-bearing activities, which means, for example, if overweight child just jumps, so that is a common activity which is included in our regular day-to-day life, right, for a child. So when the child just jumps, what happens? So the body's response is obviously going to change. So which often do not change in a child with normal BMI. Next, coming to the gait dysfunction. This also is a health consequence that should be noted in children with obesity. Common gait dysfunction such as there can be decreased velocity or increased cadence. So these are the terms, or sorry, these are the common impairments or common things that we more often do not look into. We just look into the common as a child. If a child with obesity comes to us, not many times they come, but if they come, so our major aspect would be, okay, is the child doing jumping activity, or just give the child a set of exercises and then leave. We do not go deep into assessing either the gait dysfunction. So we just look into, is the child able to walk normally? That's all. That is what we are. Ultimate goal becomes, right? So when it comes to a child, it is not the scenario. Even the number of cadence, the velocity of the gait plays a major role. That can just seem to be simple for us, but for a child, in order to match with their peers, is really very important. So we are supposed to look into those aspects also. Then coming to biomechanical changes. So for example, if a child with obesity is from 5 or 4 years or so. So if the child is found to have obesity by 3 years, and by 5 years the child comes to you, there are possibilities that you might see a deformity in the knee. I would not use the term deformity, but a postural de-alignment, such as knee valgus, and obviously there is going to be collapse of the arch in the foot. So these are the things because of the overloading that we might see in these children. These are just common examples that you would be seeing. Along with that, there are many more things that you might notice when you get a child with obesity. So that's about the consequences. So by giving a regular activity, what are we planning, or what are our major goals by having a regular activity? Not just preventing the obesity, but also promoting the overall health of the child. And the next is increasing or improving the functional independence. So here the functional independence has a different terminology. Functional independence not just means the child being able to do his own activities like just standing and walking here and there, but additionally it is the child should be able to walk from his home to the school if it is just between 3 kilometers or so, and the child should be able to just carry his bag to the first floor. Often these days, what do we see? When we were children, our parents would just come to the school gates and then just leave with our bags. But these days, children are wanting their parents to come inside the school, get their bags until the classroom, just keep their bags and then leave. It is not just because of their laziness; it is also because the children are not able to just walk carrying their heavy bags. Is because of lack of cardiorespiratory endurance. It can be because of the lack of muscle strength. So these are the things that we should focus in bringing up a child's independence, functional independence. And next is social integration. So by giving all these regular activities, by encouraging the child in performing regular activities, we are going to improve the social integration, which means the child will develop a good confidence, and the child will start interacting with the peers in a better way. So that definitely gives a good social interaction. With achieving all these three goals, the child has a good life satisfaction, which means that we might be able to give the child a good quality of life. So that's about the basics of the childhood obesity. Now coming into the role, what is our major role? So as a physiotherapist, we often forget that we also have a role in primary health care. We often think that we only have a major role in just rehabilitation after a after a patient has been affected with a condition. Only then we have a role. No, it's not that. In case of children, that is pediatrics. In case of pediatrics, our main role, we have a vast role. We often, if just as a pediatric physiotherapist, even before 5 years or so, I was just thinking, okay, if it is pediatric physiotherapist, I just have to treat a child with CP, that is a neurodevelopmental condition, a child with autism. No, it is not that scenario. We have a vast role in actually preventing the children in developing a major risk factor. So that is our major role. In a primary healthcare setup, we often do not know that. We often forget that. It's not, we do not know that. We have learned, we have, there are few people who have been practicing that, but it is because that during our training session that we have been trained in such a way that we only will be able to see a patient if they come to us. We do not go into the community and assess for all these patients. We do not go into the community or into the school checking whether the child has or might develop a problem. So we often learn something called as predictions, right? Predicting rules and all those things. We do not apply that. Predicting rules based upon the risk factor. So when we have so much of role in just preventing so many conditions, why we just have to wait until a patient becomes sick and then treat? We can actually prevent in just a patient, a person becoming a patient actually. So that is a greater part in just improving our overall society, not just us and people around us also. So that is one point that we should all remember. And I hope this would definitely be a take-home point at the end of the session. And so these are the other ones which we already know. So promoting the opportunities for the child to perform an independent activity. So our role would actually be the same as the goals of a regular activity. That those are, I've just used different terminologies here, but our roles would be similar to whatever the goals that could be achieved by performing a regular activity. So, sorry. So again, one important point here is multidisciplinary team working. So we should work as a part of many disciplines, which means here the multidisciplinary team would be not just physiotherapist, a pediatrician, and a social worker. It is a different team which comprises of a physiotherapist, a parent, definitely, that is a family member, teacher, a dietitian. So these are the different or major multidisciplinary team whom we have to keep working with in order to create good goals to be achieved for the child. So that is an important thing that we are supposed to remember in case of role of physiotherapy. And as we already saw, during that is gross motor development is achieved maximum by the age of 5 years. So during this time, yes, as we already saw some moments ago, that only between the age of 3 to 7 years, that is the development of fat tissue takes place, right? So this is a critical period when the child can actually become overweight, and this is the right time when we can actually prevent and recognize or identify a child with obesity. So as the child's BMI keeps increasing, that is, as the child becomes overweight or obese, obviously that is going to create an impact on the gross motor development also. Jumping is an example. So if a child for about 3 years is found to have a higher BMI or comes under the category of overweight, then the child will be able to do a good jumping only by 3 years. So if already the child is found to have found to be overweight or obese, the child will not be able to perform jumping at all. So that is what I mean by that would definitely be impacted, or it could be affected. So next, as I already told you, we do have to play a major role in the school. How often we see a physiotherapist in a school setup? Rarely. So I don't know how many of you have already attended a session some weeks back in the same academy of role of physiotherapist in a school, which was a nice session. So which actually tells about what is the role of a physiotherapist. So though that session dealt about a child having a particular morbidity or particular illness, here I'm not talking about a child with illness, a regular school or normal school where we have to go perform all the screenings between the age of 3 to 7 years using all the predictor rules, or just assessing for the child's BMI, assessing for the child's risk factor. Based upon this, we are supposed to encourage the child for regular activity. So those would be our role at a school. So often we tend to lack in this particular aspect. Coming to our again, so if a child, now that we have seen a child with obesity, now that we know what are our roles, so these are the general ones of what we will be assessing. For again, here an important point that I would like to tell is not often you see a child or you see a parent bringing to you a child telling my child has obesity. Often parents would definitely neglect that the child is having obesity or overweight. So the child do not come to us saying obesity, but they would have a physical impairment such as a back pain or a knee pain, or it can be any other illness also. So that rather than just looking into the specific cause, we are supposed to look into a broader perspective, whether the child is obese or overweight based upon the growth charts. So then encourage or educate the mother what are the possible problems that the child might be facing. So next, the other thing is body structure and impairments, such as a child might have problems with jumping, or what are the physical activities that the child struggles to do. Those are the other things we will be inquiring. And one other important point is medications. So in case of medications, you're supposed to ask or inquire whether the child has any other associated conditions. For example, attention deficit hyperactive disorder, the drugs or medications that are prescribed for this ADHD or autism would definitely cause overweight in children. Okay, so because of which we are supposed to ask about medication or drug history also. So coming to the test and measures, so these are the other things that we are supposed to assess, such as anthropometric measurements, height and weight and age of the child. We are supposed to match it with age matched group. Then aerobic capacity endurance testing using different measures such as just a functional test, ergometer, then circulatory system, which we can assess using a pulse oximeter or just a box exertion scale, and a functional test. So functional test and also muscle power assessment. So this muscle power assessment, though we do it for individual muscle groups, after we do it for individual muscle groups, we are supposed to, what is our end goal? Our end goal is not just to improve the individual muscle power, right? It is to improve the overall independence of the child. So for that reason, we are supposed to assess the functional part also, which comprises of the activities of the child. Few examples of the test could be sit to stand test, and you can also use standardized scales such as Brunick's Oswestry scale of motor proficiency, just a common scale which is being used for normal children and also with other children such as BCD or other problems with functions. Again, posture and alignment. Then coming to the last and final assessment, that is quality of life. So quality of life is our ultimate goal. To improve the quality of life, we are supposed to assess all these above. So to assess the quality of life, we can make use of child health questionnaire, which is again a common questionnaire that is used for children with no disability. So that's about the assessment part. So now, after assessment, we have to actually categorize the child based upon, categorize the child's function based upon international classification of function and disability. It is not that we are supposed to use this only for patients who have severe disability. As as a overall function, when you just look into the overall functional assessment, these children do have problems with activity limitation and participation restriction. So this childhood obesity is also seen as a global concern, and not only global concern but also a disability. So because of which we can apply this ICF framework for the pediatric obesity also. So example, so I would just give an example. So here the health condition is pediatric obesity. So the body structure and function that is affected for the child can be just a knee pain, for example. So activity limitation, because of the knee pain, the child might not be able to perform the common activities such as jumping or walking. Because of this common activity, because of the child not being able to perform this common activity, the child will definitely have a participation restriction. Participation restrictions such as the child will not be able to play with the peers in the same level. For example, and when for a child of 5 years or so, the child has to jump and just run fast. So this peer is able to do that activity in a good way, whereas the child with obese will not be able to perform it in a similar way. So because of which the child would not participate in that activity at all. That is what we call it as participation restriction. So then after finding all these different frameworks, we are supposed to check what can be the possible factors that is causing an activity limitation in the child. It can be a personal factor or it can be an environmental factor. So personal factor can be such as age of the child or gender of the child, or environmental factors such as it can be due to the parental influence, it can be because of the nutritional deficiency or overloading of nutrition. So these are the different factors that should also be assessed. So coming to the barriers in managing childhood obesity. So we have three important barriers that are obstacles in before we go to the management of a child with obese. It is resources barrier, we have a social barrier and an emotional barrier. So resources barrier are financial barriers, limited time, access and availability of program knowledge gap. So financial resources, which means the parents would not be affordable to join or put the child in a class because of larger families and limited time, as in the current situation or the current generation, both the parents are working. The parents will not be able to spend enough time with the children for exercise session. Then access and availability, so it can be because of the lack of availability of the programs within their reach. And another important cause can or barrier can be the knowledge gap. Knowledge gap means the parent not knowing the health consequences of obesity or not knowing what are the healthy foods that should be given for the child. So those are the knowledge gaps. So these are the common resource barriers And next is social barriers. It can be similar to the financial resources because of a larger family, not only because of the larger family, but also and we have a certain type of foods that is irrespective of what those are the foods that would be given in a few cultures, right? Even if it is just a 5-year-old child or if it is a 50-year-old adult. So those are the, we have few common foods that would be given equally for all these different age groups in few cultures or societies. So that also plays a major role, or it also becomes a major barrier. Next, coming to emotional barriers. So in case of emotional barriers, lack of confidence. Here, the lack of confidence is not just in the child, you just do not see this lack of confidence in just doing an exercise for a kid. It is commonly seen only in parents who feel that they will not be able to manage their child's weight and defeat once they might have tried or doing an exercise or educating their child in performing exercise of which they might have not succeeded, because of which they also might not accept that or willing to change or repeat doing all those exercise physical activity once again. So next one another aspect is loneliness. So this all can be overcome by the child's parents. When the child performs exercises with their parents, all these emotional barriers can be overcome. We can overcome all these problems. So coming to what are the facilitators to managing a childhood obesity. So previously we saw what are the common barriers in just prescribing or managing a child with obesity. So these are the facilitators. So first is, or what are the points that you should look into to treat a child with obesity. So first is building partnership, which means we just should not as I already told you, it is not only a role of physiotherapist, but also it is the role of a parent, it is a role of a teacher, it is the role of a physical educator, it is the role of a nutritionist or a dietitian. So we have many people, many roles we just have to work as a team, as I already told you. So we have to start building up partnerships so that we'll be able to manage or help in accessing the resources for the parents. So access the resources, which means by building up partnership, it facilitates or enhances for us to reach the resources easily. So thereby we'll be able to teach the parents. So, for example, it can be teaching a child, a mother, or older child in just cooking how of a healthy meal, or just classes, a good recreation classes. So maybe somewhere between the area of accessing between 3 kilometers from their home. So those are the different types of resources that should be accessed, or we play a major role in helping the parent access all these resources. So next, consistent encouragement. So this encouragement can just seem to be very easy. If you see in the pyramid, I've just put it in the last, but it has a major component. It plays a major component because without this consistent encouragement or consistent feedback or motivation, either the adult, that is the parent, or the child would not be able to control or manage obesity. Or we often lack confidence at one point of the time when we are not able to succeed, right? So for that reason, we always need this dosage of motivation or encouragement consistently. Next, in case of managing, now that we have seen what are the facilitators that we could use in enhancing the management. So before we could actually go into the prescription of exercises, the physical activity, we are supposed to look into the stages of change model. So this not only can be seen in children, it can be applied to any function or any group of people, or when you try to perform a particular task. These are common stages that we undergo, right? The first is pre-contemplation stage, where we do not acknowledge our change in behavior. So, as for example, here we might take as obesity. So the parent might not know that the child has obesity. It is different from accepting whether the child has obesity or not. Here, the parent will not even know that their child comes into the category of either obese or overweight. Then is the stage of contemplation. So this is a stage where the parent or as a person, we know that we have some problem, but we are not ready to change. Because if we change, it requires more energy. It can be any reason, because of our laziness or anything. So this is the time when we know we have certain problems, but we are not ready to accept the change or make the change. Then, so the next stage is preparation. So overcoming all these, all the first stage, few people tend to go to the next stage also. They start preparing how to make the change, and then they actually make the change, and then they are able to maintain the change. And then comes the last phase, which is actually it can actually lead to the next phase. So we maintain performing a particular exercise for a good period. So what happens? Everybody needs a rest in between. So after a rest, we have to actually go with the relapse, which means we have to we have to just continue. If we do not continue, there are chances that we might just stop in between and go back to thinking that, okay, I've been doing my physical activity or my task for a certain period of time, so that my task is completed, and I need not go continue this particular task for a long time. So that is the mentality often people have, not knowing the duration or the consequences that it might lead to. So if the person do not does maintain, then no problem. So if after maintenance, if a patient stops in between, or anybody stops in between, then he again goes back to the pre-contemplation phase, not knowing that they still have that particular problem or a change in behavior. So why this is important is we have to put the parent or categorize the parent. Here we are actually categorizing the parent in this childhood obesity. It is because parents are going to play a major role along with the children in treating this obesity, right? So for that reason, first you have to put the parent in these, find out in which stage the parent is, then you go try to apply the same stages of changing model in children. So after which we give this chart to a parent. We ask them to actually identify these are common problems or causes that anybody would be able to actually identify. So give this to the family, or saying what can, or you can just go with and identify what can be the common causes, and then we are supposed to get the family involved, then decide upon the food that they should be taking based upon few charts, or then prescribe them more of physical activity. So these are just examples, and these you can make use of such food charts to explain the parent. So how much amount of green leafy vegetables or fruits that they should be consuming, and how much amount of proteins that they should be consuming, and how much amount of fat that they should be consuming. Okay, and on the right we have so this is what are the physical activity or what could be a prescription to manage obesity would be not we cannot for example, if it is flexibility for an adult, we can just go with an active exercise, that is an active stretching or a passive stretching, a self stretching, and all those things. Even to improve a strength and endurance, we can just ask the patient to just perform a muscle power in order to improve the muscle power. We can just ask them to perform a resistance exercise and active exercise and all those things. But when it comes to children, we cannot apply that. It is not, we cannot apply that. They will not be able to not only comprehend, but also they will not be able to do that in a enjoyable manner. So for that reason, we definitely have to include or try different type of activities, such as yoga, which is a major part of flexibility training. And if we have to improve the cardiovascular endurance, then we can just try with walking, cycling, aquatics, Pilates. So these are the different types of exercises or training that you can prescribe. So along with all those things, as I already told you, motivation plays a major role. Because of this motivation and encouragement, consistency can be maintained or can be seen in children and also in the parent. Next, coming to what are the encouragement, what are the parts that we are supposed to encourage and discourage a child, or what are we supposed to encourage, or what are we supposed to do, and what are the things we are not supposed to do. And first thing that comes in encouragement is fitness education for family members. We are supposed to encourage, not only we, this should also be taught to the parents also. After a physiotherapist, it is going to be the parents who will be playing a major role in managing a child with obesity, right? So first is, we are supposed to encourage family fitness, not only for the child but also for the other family members. Then having fun with kids. Fitness, I have one of my teacher who is around 40 years and he still does, he's very fit, he does exercises regularly, and looking at him, he just performs his exercises in such an enjoyable way. Looking at my sir performing exercises, his son would often come to him asking that his son is of 11 years or so. He often comes to my sir saying that even I'm interested to do all the exercises that you have been doing. So that is how the level of commitment from the family members, that is from the parents, should be shown in case of fitness. So next is having fun with activities, not just giving them random activities or physical activity. They have to actually enjoy doing all those, and start with not just moderate or high intensity, just with lower intensity exercises or other physical activities. And then we are supposed to, as we already told, it is a not just a single man army, it is a group therapy or a group of families and such as a teacher and a dietitian. We have to include all these members in also identifying the goal that we are supposed to achieve. Yes, and next, obviously, to improve the quality of life should also be our major goal. And one of an important point that we should remember here is give positive reinforcement as appropriate. So which means we often see as a parent, when the child just performs exercise for about 5 minutes or 10 minutes, parent says, oh wow, yes, okay, that's fine, you've done an excellent work, now you have started sweating, please stop. So even as an adult, we still see this, we still face this. Even now our parents do tell all these things, but these are not called as positive reinforcement. Here I've mentioned it as if positive reinforcement as appropriate. Only once the child does complete their task is supposed to go with the positive reinforcement. So those are the things that we are supposed to encourage. And what are the things we are supposed to discourage is, again, we are not supposed to compare the child with the groups or with the peers of the same age. See, he is able to do, he's able to perform that particular activity in a better way, but you are not able to perform. Those comparisons should completely be avoided. That can lead to psychological problems, issues in the child very early. And next is participation. So we often ask children as a parent, parents often ask children to just not only participate, you have to win, not just inculcating the mindset of winning, but the child should actually enjoy participating. So often we our parents only tell that, not our parents, maximum of the parents only tell, you have, if you participate in something, you should be the first person, you should be the person to win the medal and all those things. That is not the way we are supposed to encourage. We are supposed to actually encourage the child, saying that your participation is more than enough. If you are able to satisfy yourself, if you are able to just participate, give your maximum, and that would sufficiently be enough. So those are the words, or those are the things that we are supposed to tell the child. And next is, there should be a gradual progression. And next, exercise. You're not supposed to give a strict demand for the child, saying you should do, or if you do, I'll do this or that. Should not be that way. It should be that the child should actually enjoy exercise, enjoy doing a physical activity, and that should be his own reward. So that comes to the conclusion. That makes me come to the conclusion of the session. So these are a few apps. So now, as we are living in the age of technology, so these are the few apps that can be, which is free, that can be used or advised for parents to perform physical activities. All these are age matched, which can be used for children between 5 years or 2 years or 7 years. So similarly, each app has its own recommendations. So based upon that, some common activities can be given in an enjoyable manner. So coming to the conclusion, that is just a summary of what we have discussed. So 5 to 12 years is the common age group where we see this obesity to be really alarming. So this is really a cause of global concern, which we all should be aware of and be ready to prevent. And majority of this condition is caused due to the technology that is being prevalent right now, which leads to maximum of inactivity. So what can be the management? Obviously, physical activity is more than enough in order not only to prevent, also to train the child or treat the child with obesity. And coming to the final part, obviously, as I already told you, school, more amount of researches are important, not just in, even if we see in colleges, we just ask students to do an RCTs, that is randomized control trials, experimental studies, which is not practically possible every time. So we should be focusing more onto studies which would actually show us what the problem is. Only if we identify what the problem is, then we'll be able to identify the management for that particular problem, right? So it is the time we should start doing more of research or more actively work in the school setup, start screening children who might be in a stage to develop obesity or overweight. So again, do remember what I was talking about, the primary health care. As a physiotherapist, we have a major role which is to be played even in the primary healthcare setup. So that is the conclusion. So this I end with the quote stating, together we can and will reverse the trend of childhood obesity. So together, which means all the physiotherapists over here and also creating awareness between or among the society which comprises of majority of parents. With the awareness being created, we could definitely reverse all these trend of childhood obesity. So now we are open for questions.
Thank you, Dr. Janani Ravi, for a wonderful session about childhood obesity. There were some questions in chat box. I would like to call Dr. Rupesh. Are you there? Okay, okay.
Please wait, I am unmuting you.
Okay.
Rupesh, you can unmute now.
Yeah, ma'am. Yeah. Yeah. Very nice presentation, ma'am.
Thank you, sir.
Yes, ma'am. First question is from Dr. Rinku Singh. According to the village, why are the city's children obese?
Okay, this is a very practical question, ma'am. So, as we already know, children in villages, okay, in the current generation, after 5 years or so, if we do a research, definitely both in the village or both rural and areas are going to have, urban areas are going to have equal prevalence rate. But previously, it was so because of the technology and children's. If we see even now, just walk miles to actually get their education. They just do not sit with their mobile phones or the great technologies to actually enjoy their. So that is one of the major reason which can be um, which can lead to childhood obesity or prevalence of childhood obesity among the urban areas.
Yes, ma'am. Next question is from Miss Sweta. In schools, how should we examine the children, ma'am?
Okay, so for example, if we have few predicting scales, or we just can go with basics, such as we just, for example, if we go to a school of LKGs or a group of LKG students around 3 years or so, or 4 years, we just can screen their basic age and the height and weight, and then we can just use our age matched see growth charts. Just with the growth chart, we can just screen the children's. Do they come in the proper BMI, or is there any exceeding, or does the child come under under nutrition?
Yes, ma'am. And next is from Miss Maniyarasi. Maniyarasi, can you unmute yourself? Your question is unclear. Maniyarasi?
Now?
Okay,
She's
ma'am.
not unmuting. You can go to next question, I think.
Yeah, ma'am. Next is from Miss Asta. Ma'am, even in some areas, people don't believe in obesity. They brush it off as a normal thing. How we can make them believe to concern about their child obesity?
Okay, so again, another practical question. So as I already told you, it is very important for us to create awareness among parents. So one example I would like to tell is we just need not just go to community and tell each and every parent that children have obesity, or children have your child has obesity. But one important thing that we are supposed to start doing right now is, if we have a patient coming to us, and if we see that patient bringing their child having obesity or in the overweight category, irrespective of whether the child has come to us seeking for help or not, we are supposed to stand in front in preventing the child in developing either overweight or obesity. So that is you cannot just talk to people who act as deaf, right? We are supposed to talk to people who are at least open their ears to listen to whatever we say. So that is how we are supposed. We can also create some awareness programs in the schools, bringing their parents, telling what are the problems with other nutritionists or dietitian in the role, explaining what can be the problems.
Yes, ma'am. And few appreciations in between, ma'am. Yeah, next question is from Ms. Maniyarasi. Sir, how to cure obese in starting stage and diet for it, and how treat them easily?
I still do not comprehend your question.
Maniyarasi, you can unmute yourself. Any other questions, dear participants?
He's asking for a diet actually.
Okay, fine. So as I already told you, when you see about diet, it should comprise of more than 5 servings of green leafy vegetables or fruits, and it should comprise of very less of not carbohydrates, very less of sugary substances or sugary liquids. So that is about the diet that you should be including along with the diet. So physical activity should also be included. That also should be treated or taken as a diet prescription.
Any other
Yes.
questions?
Any YouTube questions, ma'am?
No, sir.
Many appreciations are there, no questions in you.
There is a question from Venkateshan, sir. Can you please update about triponderal mass index?
Can you please explain me the question once again, sir?
Just a second, hold on.
Please update about triponderal mass index.
Okay. I just do not comprehend.
Okay. Move on to next question, please.
Yeah, next is from Dr. Arnachalam, sir. My son asked, if I exercise, will you get me ice creams?
Sir, those are the things that you are supposed to discourage, sir. So that is not a positive reinforcement. So you're supposed to make or prescribe exercises in such a way that it becomes an ice cream for your child. Or the exercise should give him happiness similar to the ice creams that you'll be giving your child, sir.
Yes, ma'am. Exercises as ice creams. Yeah, ma'am. Next is from Carmeletta. Ma'am, what are the main exercises that we can focus on in order to reduce obesity?
Okay, fine. So I would not just tell you exercises as such, because first is to prevent, you definitely have to go with 60 minutes of moderate to vigorous activity, a physical activity. So if you see exercises in order to manage obesity, then I would suggest you to go with yoga, then cardiorespiratory endurance such as aquatic therapy or yoga therapy. So these are the few things that might help the child as a whole. Parents tell.
Yes, ma'am.
Any other
Next
questions?
is from Miss Aishwarya. Many parents tell if the kid is doing exercises, they won't grow like that. How do you see this kind of parents, ma'am? How to tell this will not happen in them?
Like I told, we have different types of parents. So there are few parents might accept what we say, and few parents might not accept what we say. It is just a lack of their awareness. We have to keep educating the parents regarding what might happen, what are the good outcomes if they perform physical activity. You're not going to just prescribe them exercises as such, as I already told you. You're just going to encourage them in performing activities or training them in different aspects. So you just have to go with more of parent education, not just child. Here the child will do all the exercises that we prescribe, or all the training that we give, but the parents might offend, saying these are the problems that my child might develop. So in those cases, parent education is very important.
Yes, ma'am. Any questions?
No more questions are there, and we can conclude, I think.
Yeah, Chandramohan sir.
Yes, please. Any other questions, Rupesh?
No, sir. No.
From YouTube?
Sir,
No, sir.
no questions are there, only appreciations.
We will conclude, okay? Thank you so much, Dr. Janani Ravi from SaiRaM Academy, one among our associates, for taking a very interesting topic today and need of our too, because even the adults are sitting at home now, and this is especially eye-opening for many, so that they can concentrate on their child. And I thank all our associates for this WEBATHON series, which is powered by Dr. Venkateswaran's Stimulus Physiotherapy and Fitness Clinic, Pune, Maharashtra, India. I thank all the participants, and I thank ExRxIndia team members, Dr. Rupesh and Professor Luna, everyone. I thank you all. Good night. Bye-bye.
Thank you.
Good night, Janani.